Welcome to Neonatal Impedia, your trusted source for neonatal parent and provider information.
Hey guys, welcome to Neonatal Impedia. Today I have a couple of videos that I'm excited to do. I had a special request from a neonatal nurse practitioner student to do a video on how to round and what the different parts of rounding means, and also how the different parts of writing a progress note. So I hope you guys enjoy. Okay, so first I'm going to kind of discuss what rounds in the NICU look like and what rounds are. So rounding in the NICU is a multidisciplinary team, and it includes the neonatologist, nurse practitioner, the bedside nurse. The parents, of course, are always invited, and we really want them to be a part of rounding as well, because you do know your baby best and you have concerns and questions that can easily be answered during rounds. We also include neonatal RTs, the respiratory therapists, pharmacy, dietary, and social work and care coordination are usually involved as well. So this is a time for you to ask questions. If there's any concerns with the baby, those are brought up during this time. And then if you have any, needs outpatient or outside of the hospital, we can have those addressed as well. So after we address the needs, and what will happen is usually the nurse practitioner or resident will present your baby to the attending, and everyone involved will listen. It starts with what we call a one-liner about your baby or about the patient. And then we go into subjective data, what we see, what's happened overnight, objective data, so we can look at the vital signs and the physical assessment, anything like that. Then we also talk about an assessment of the baby, and then the plan of care for the baby. And this is when we decide the plan of care for the baby, if we need to make any changes, what's working, what's not working, to ensure that your baby continues to do well. Okay, so for my novice nurse practitioners out there, let's kind of talk about your role in rounds, what you need to be prepared to do. So the biggest thing I can tell you is be prepared, know your patient, make sure you come in early, gather your data, make sure you understand your patient's diagnoses. You want to make sure that you look at vital signs ahead of time. You want to talk with the nurse to see if there's been any changes overnight. Look at the MAR, or the medication administration record. Make sure you know what medications the patient's on. And then if there is any lab results from overnight, make sure you write those down, and also make sure you know the ones that were before that. You don't want to know just if this one lab value, because that one lab value might not mean anything if you don't know the lab value before that. So always make sure you have a record of the past history of the patient. You also want to see if there's been any radiology findings, if the baby's had any cranial ultrasounds, any chest x-rays, anything like that in the past 24 hours, and make sure you're prepared and have that stuff available to you as well. Okay, so the next part of rounding is to establish your rounding team. We talked about this a little bit earlier, but let's also discuss know your neonatologist. Who is a neonatologist? He is a sick baby doctor. He or she is a sick baby doctor. They are pediatricians who have specialized training in the NICU, and they have that additional critical care experience specifically for neonates. Then you'll have your nurse practitioner. Your nurse practitioner is a RN who has an advanced degree in neonatology, and they are a part of the medical team, and usually they're the ones that are presenting the patients. You have your NICU RN, who's the bedside RN. Then you have your neonatal respiratory therapist will be there. They're the ones who manages everything that happens respiratory-wise or with the lungs of the baby. So they are the ones who manage the ventilators, the high-flow nasal cannula, any oxygen the baby's on, that is their area of expertise. Then you might have a neonatal pharmacist. This is a pharmacist who specializes in neonatology. They know all your baby's drugs backwards and forwards. So this way they're able to make changes to dosages. They help out the medical team a lot with weight. If there's a weight change, we will call what's weight adjust the medication. And they also are really good about reminding us when the baby needs to be started on certain medications, such as multivitamins, iron. If the baby's due for their immunizations, they'll let us know those things. And these are the type of things that we discuss during rounds. The neonatal dietitian, they will be someone who helps look at your baby's growth. So where the medical doctor and the nurse practitioner, they are looking at the overall care of your baby, you have these different specialties that look at specific parts of your baby's care, such as, you know, your baby's weight or how many calories your baby's getting in. If your baby needs more calories, they are the ones who is the advocate to make sure that they're getting the correct nutrition they need for their gestational age. And then your care coordinator or social service person, social worker, they are there to help you if you qualify for any services, government services, Social Security benefits, if you qualify for WIC or Medicaid. They're the ones that help you bring all that information together, and they're a really great resource for community resources as well. So just to reemphasize, the goal for rounds is to make an appropriate medical assessment of the baby daily. So rounding happens every day. Some places it happens twice a day. And then you also need to come up with a treatment plan. So this is going to be your plan of care. And we come up with a new plan of care for each baby every day. And then of course, as needed as well. Rounding is also a great time for family communication. And so there again, we really encourage families to be a part of this process. It's so important. And I feel like families feel the communication's a lot better when they're a part of rounds, and they feel like they're a part of the medical team because they are. Another great part of these rounds is the discharge planning. We're able to look, and just like I was saying, the pharmacist will tell you if you're ready for your 2-month immunizations. This is a time where we're able to say, okay, what do we need for baby John to be able to go home this next week? We need, you know, all of our outpatient appointments made. We need hearing screen. We need car seat testing. And we're able to, together as a team, make sure everything is in order so we don't delay our discharge any. So for the part of conducting rounds, this is more for our nurse practitioners, because usually it's the nurse practitioner or it's the resident who is going to present the patient. So you want to start rounds, like I said, very prepared. After that, you need to have an outline of how you want to present your patient. And it can kind of be like a SOAP note. So subjective, objective, assessment, and plan. And this way, you can also go by a review of systems to do this. Some places do go by diagnoses, but I've just always found it easier if I go down a list of the different systems and discuss any pertinent diagnosis as a part of the system. So one thing, especially if the patient or if the neonatologist knows the patient, you want to start with a one-liner. So I'm going to give an example of a patient, and I'm going to actually do rounds on a patient and say that. And after I have finished rounds, I want to discuss each part of these rounds with you so you know exactly what they are. Okay, so I'm going to start rounds now. And afterwards, like I said, I'm going to go through and explain what I've said, but I wanted to give you an idea of kind of how to start rounds. So always kind of start with a one-liner. Now, if your neonatologist is new to the patient, you need to make sure that you give a background and history, maternal history, why the baby was born, you know, C-section vaginal delivery, if there's any, you know, pertinent prenatal labs, anything that is necessary to take care of the baby. Always be objective with that information as well. So I'm going to start rounds now. One thing I also want to remind you is always use the baby's first name, if at all possible. If you know the baby's name, it makes it more personal. It makes the family feel cared for, and it's the right thing to do. Okay, we don't want to say baby boy in room 3. So this is baby boy John Doe. So John is a 24 and 3 weeker who is now day of life 2. He is corrected to 24 and 5 weeks. He had no new events overnight, and his vital signs are normal. On physical exam, there's really no changes. He does have a grade 2 murmur, and he does have some crackles in his lungs. So respiratory, John has RDS. He is status post surfactant ×2. He is on conventional ventilation on a rate of ACPC. He is on a rate of 40 and 21/4. FiO2 has been 23 to 40% in the past 24 hours. My plan for the day, and his morning ABG was 741, 42, 68, -1. So my plan for today is to begin weaning his pressure since we're on ACPC mode. And we're going to wean him to a PIP of 20. We're also going to wean his FiO2 as able, and we will consider another dose of surfactant as needed if FiO2 remains above 30%. Cardiovascularly wise, he does have a murmur. We have not done an echo yet. If he continues to require excessive oxygen, we will go ahead and do a murmur, or if the echo if the murmur persists. And then he did start having some hypotension yesterday, and he is on dopamine 5 mics per kilo per minute. His blood pressure maps have been 25 to 30 in the past 24 hours. So we are going to continue weaning our dopamine as able, and we are going to consider hydrocortisone if we are unable to wean off the dopamine. Heme-wise, John's initial crit was 54. This morning it was 48%. His platelet count has been normal. It is 205,000. He does have hyperbilirubinemia of prematurity. His bili this morning was 10. We did start phototherapy by double banks, and we will monitor his crit and platelet count and bili in the morning. FEN, John was initially NPO. He was started on vanilla TPN at 80 per kilo per day. On admission, he transitioned over to TPN and lipids yesterday on day of life 1. We are going. His BMP is normal. His sodium was 142, which was up slightly from 140. His potassium was 4. His chloride was 112. CO2 was 20. BUN was 30. Creatinine was 0.81. And his glucose was 75 with a calcium of 9.5. So we are going to increase him from 80 to 100 per kilo of fluids, of TPN and lipids. I'm also going to start trophic feedings of human milk or donor human milk at 1 ml Q3 hours, which is 20 per kilo. And we will repeat a BMP in the morning. His urine output has been great at 4.5 mLs per kg per hour, and we will continue to monitor his urine output. Neuro-wise, he has a normal neurologic exam for gestational age. He is at risk for IVH, and so he will get a cranial ultrasound at 7 days of life. And then ID, John was born via primary C-section for maternal preeclampsia. We did do a CBC and blood culture on admission. His CBC was reassuring with no bandemia. His blood culture is no growth to date, and he is not on any antibiotics. So we are going to continue to watch his blood culture and repeat his CBC as needed. So that is pretty much how you need to go through your patient. Notice I did mine by systems. It makes it easier for me. And so I always do my assessment of the patient, so my A, and I do my plan together, but with each system. So other places, and it really just depends on the preference of the neonatologist, some want you to go through your assessment and then do your plan at the end. Either way is fine. Neither one is wrong. It's just really based on preference and how you're used to doing it. So I kind of gave a little bit of a one-liner at first. So what a one-liner is, John is a 24 and 3 weeker who's now 2 days old, which is corrected to 24 and 5. His weight today is 525. He had no events overnight. He remains intubated on conventional ventilation, NPO with TPN and lipids. So that can kind of be your one-liner at the beginning. This is what happened, or some people might call it a interim summary. So this is what has happened in the past 24 hours. This is how you are explaining to your neonatologist exactly what your patient is. 24 weeks on the ventilator, NPO. So those are some of the big things that's going on with him, right? So then you want to go through your objective data. Vital signs are stable. If he had any apnea and bradycardia, anything that basically you see in the chart that needs to be noted during rounds, mainly vital signs, A's and B's. If there were any new events like intubation or he required a blood transfusion, anything like that, this is where you could say that. And that's when you start coming through your plan and your review of systems. So respiratory, his assessment is so what an assessment is, it's your assessment of the patient. So my assessment of the patient is that the baby has respiratory distress syndrome. And because of that, he is on conventional ventilation. He has received surfactant ×2. And he had a good blood gas. This is the blood gas. It was acceptable, so we're going to start weaning. And that way you can kind of go right into your plan and say, okay, my plan is I'm going to wean this baby's on the ventilator. And then you go through each one of your systems like that, and there might not be anything to change. So we'll just continue to follow. And that's fine to say too. This baby, of course, I use the 24 weeker because they have a lot of things with each system that needs to be said. And of course, there will be interrupting. I didn't discuss any medications. And that's where, like under CV, I could also, the baby's on dopamine and we're on 5 mics per kilo per minute. Are we titrating? Does pharmacy need to make any adjustments? Do we need to change the volume that the bag is in to make the rate smaller so we're not fluid overloading the baby? This is a time to do all of those things. You as a nurse practitioner are the one to facilitate this conversation. You need to have a plan for what to do for the baby before you come to rounds, and then let others take the suggestion, make suggestions, because there's going to be things that everyone forgets. The big thing about a nurse practitioner and neonatologist, they are looking at the baby as a whole. And we are so lucky that in our field, we have different people who look at the baby in the smaller sets of their systems, so we make sure that we don't miss anything. So then after the patient's presented and all different specialties or disciplines have had a time to say, this is what we're going to do. This is John's plan of care for the next 24 hours. This is a great time for you to call and update the family or talk to the family at the bedside. See if they have any questions while it's fresh on your mind. Make sure that one of the most important things we do in our job is to communicate with families. I actually went to a conference the other day, and I was in Uber, and I had a parent of a NICU baby whose baby was 4 months old and she was still in the NICU. And I asked him, I said, what could we have done differently for you? I didn't know this patient. I didn't know him. All I knew was he was a NICU dad whose baby was still in the NICU and had been there for 4 months. She was close to coming home. But I said, what could we have done differently? And he said, once my baby got a little bit better, they stopped calling me and updating me. And that really hit me hard because I have definitely sometimes put that on the back burner when we're super busy, or when you have a super critical baby, you want to make sure to update that family, but you don't think to update the ones who are so close to going home. We need to make sure that we continually update families and communicate with them, because this is their baby and this is such an important part of their life. And we just need to make sure that we can do everything we can for them to understand the process. So I hope this has helped you guys. If you have any questions or if I missed anything, please let me know. Send me a message, comment below. And if you have any more topics you want me to discuss, I would love to talk to you about them. Next time, I will talk to you about how to write your progress note, which is a lot like how I round. So it's really a lot of the same. You just need to remember that your assessment is the way you perceive what's going on with the baby. You make your diagnosis and you decide what you want to do with that diagnosis. All right. Have a great day. Thank you for joining us at Neonatal Impedia. Thanks.